when we talk about retinitis, again, we know a lesion which is in the retina, and this is more superficial, which is fuzzy margins, creamy lesion. And again, you have hypofluorescent, lesions. They could be leakage, fuzzy borders. And then you have characteristics on OCT like vitritis, hyaloid thickening, retinal disruption, retinal thickening. There are lots, retinal hyperreflectivity, interruption of the ellipsoid zone, the RPE elevation, hyperreflective oval dots, subretinal fluid, hyperreflectivity of the choroid. Now, are these parameters going to help us in identifying retinitis? So when we are looking at differentiation, what are we looking at? Are we planning to look at certain biomarkers which would be able to tell us the etiology? Are we planning to look at certain indicators which would also give us the prognosis of that particular case of retinitis? So when we look at retinitis, we are usually talking about infective necrotizing retinitis. And as we all learn and have learned and we've practiced all along, that these are associated with characteristic clinical patterns, like in toxo, ARN, cytomegalovirus, or syphilis. There's a distinct clinical pattern. And we confirm it with a serology or molecular diagnostics from the fluid. The problem comes when we deal with atypical presentations. So that is in immunocompromised individuals, when you have acquired toxo lesions, viral retinitis with varying presentations, and now what we are seeing more commonly, the post-fever retinitis. We don't know whether it is infective, we don't know if it is immunological, and of course, bacterial retinitis. So as he gave us this talk, I just went back and looked at the literature, and I found quite interesting articles, and some of the authors are here. So any questions can be directed to them. And this looked at basically looking at whether you could look at the OCT findings and tell to what etiology this retinitis, what is the cause of this. But it is unfortunate that these are very limited cases. So the first series had only 5 cases, 1 of toxo, 3 of CMV, 1 of VZV, and other had 20 eyes. And they have been able to do the OCT on 20 eyes with 10 of toxo and 10 of viral. So again, this is a small number, and we will need to take it with a pinch of salt. As I'll show you, this is a Toxoplasma retinitis. And again, you have all the characteristic findings on the OCT which we have described. But what is interesting, which the authors have described in those 2 articles, are these round deposits on the retina. And you have a hyporeflectance of the choroid with an RPE elevation. So these are, when they compared it with the viral retinitis, the toxo group definitely had this, and none of the viral eyes had any of these differences, and especially the changes in the choroidal architecture. Now, when we look at the pathology, again, you have a chorioretinal involvement in patients with toxo, so probably this is justified changes in the choroidal architecture. Now, this is again where you could use the infrared to delineate the retinitis better, and here again, you're getting back the choroidal architecture. It's starting to come back as the lesions are resolving, and there is resolution of the fluid, but the outer layer looks relatively okay. Now, in comparison, the viral retinitis, you have more of an intraretinal, and you have the lesions. Again, they have mentioned that there are these hyperreflective vertical bands, which are usually seen in the outer nuclear layer, and they are supposed to be the infected Muller cells. And this is more commonly seen in patients with viral retinitis rather than in toxo. So again, this is an article which cites that, and if you can see the hyporeflectivity of the choroid, all their 10 cases did have in the toxo group, whereas none of the viral had. And also the choroid involvement is much more common with the toxo, and it's not seen in the viral, in comparison with intraretinal edema and hyperreflective vertical strips, which are more common in the viral. Now, there's another paper which shows about the cytomegalovirus retinitis, which shows these kind of volcanic eruptions, which are seen in patients with CMV retinitis. This is the vitreous finding. And they've characteristically described the CMV retinitis 2 types of findings, where you have a full thickness retinitis here. And there's another variant which is called a cavernous type on the OCT. Now, what is important is they have described the ones with the cavernous are the ones usually who progress to retinal detachments. So this is something interesting, and I think we need to go back and look at our patients as well. because all these we had really not seen much in detail initially. Again, another important distinct entity is the syphilitic plecoid courier retinopathy, again showing diffuse leakage. And if you see the OCT, again you have these kind of nodular lesions on the retinal pigment epithelium. There's so much of hyperreflectivity. And then you have this kind of hyperreflectivity of the choroid as well. And there are breaks in the epiretinal membrane. But the interesting part is usually this type of retinopathy normally is reversible. And with treatment, again, these lesions start getting better. So these are some of the characteristic descriptions which are usually seen in syphilitic plecoid courier retinopathy. One thing which was interesting is this post-viral retinitis, which we are beginning to see more often. Some of them respond very well and they have a very good prognosis. Some of them land up with a lot of exudation. So again, this is one such case, again post-chikungunya, and this patient was on steroids as well. And these are the autofluorescence, doesn't show much, I mean, you don't get more information right with this. Again, here you have these kind of full thickness, you have in the hyperreflectivity of the retina, and these kind of deposits, again with some fluid. Now, this is again an FFA showing kind of leakage hypofluorescent areas, but look at the other, this is the OCT. Again, the lesions which was described in Toxo, where you see these round deposits on the retina, you do see it in this as well. So, I mean, there are a lot of overlap, and it is, unless you have a lot of cases to really put your, and say this is a biomarker, it is difficult to really comment. But what is interesting is many of our patients with post-fever retinitis land up with a lot of exudation. So this is one such patient, and if you see, there are kind of these lesions over here, and probably because of these it's something like a RAP lesion, but there's so much of exudation, and these patients did very well with anti-VEGF and Ozurdex injections. Unfortunately, we could not do OCTA in these patients because of the serous elevation which was there. And this is again the OCT, which shows these kind of round deposits which are there on the retina, thick posterior hyaloid. Again, you are not seeing the choroid very much, and there's a lot of fluid. So to assess the visual prognosis, again, it has helped in the sense these patients have done well. So when you look, they look terrible, but then over a period of time, the layers are quite okay. So they land up with a good prognosis in comparison with outer retinal necrosis, where you have the whole outer retina gone, so you're not able to see the retinal pigment epithelium, the outer nuclear layer is gone. And this is what happens post about 3 months down the line. The whole outer retina is atrophic, and there's so much of diffuse choroidal hyperfluorescence. But this is again, the retina is thinned down, and the responses on the electroretinogram is very poor. Now, this is one of similar reports which was described by Kalun et al., where they have this very mottled autofluorescence, and you have these kind of multifocal hypofluorescent lesions along the veins and complete hypofluorescence of the arteries as well. So, to conclude, multimodal imaging have helped us understand the retinitis better. It has been able to help us predict the outcome of retinitis and the visual prognosis in many cases. But whether you can differentiate the etiology of the type of retinitis, again, you need a lot more data to identify the biomarkers. And of course, the time is not very far when we have advancements in technology, and we should be able to do that as well. Thank you very much.